Hello everyone, welcome to a very interesting session on systemic lupus erythematosus. So, as far as systemic lupus erythematosus is concerned, it is one of the most frequently asked essay question in your prof exam, and rather than being important for your university exams or your prof exam, systemic lupus erythematosus is one of the autoimmune disorders which must be discussed in all aspects. That means its etiopathogenesis, the various spectrum of autoantibodies, then the criteria, recent criteria as per the American College of Rheumatology or the EULAR classification 2019 updates. Then 21st edition of Harrison, some updates has been made. Then from the 10th edition of Robbins. So a lot of updates has been made regarding the clinical features, diagnostic modalities, treatment, everything of the systemic lupus erythematosus. So I have decided to discuss about the systemic lupus erythematosus in its whole aspect. Fine, that is all dimensions. So I have included the pictures from 10th edition of Robbins, from the Harrison, ACR, American College of Rheumatology, EULAR classification of systemic lupus erythematosus, the 2019 classification, everything. So before going into the topic, so let us see what is actually the systemic lupus erythematosus. I have already told in my session on autoimmunity that the systemic lupus erythematosus is nothing else but an autoimmune disorder. It's an autoimmune disorder which is going to affect multiple systems. So that's why I call it as a systemic autoimmune disease. That's why I call it as a systemic autoimmune disease. So actually what is SLE? So these are straight lines from Robbins. Multiple organ involvement, autoimmune disease with a wide variety of autoantibodies, particularly anti-nuclear antibodies. Fine. There will be deposition of immune complexes. Yes, can anybody recollect from your previous or from your knowledge what type of hypersensitivity reaction the systemic lupus erythematosus is? Yes, anybody? Very good. It is type 3 hypersensitivity reaction. It is type 3 HSR, hypersensitivity reaction. Fine? Yes. So there will be injury to the skin, joints, kidney, serosal membrane, everything. And remember, any organ can be involved. So the patient, there won't be some classical clinical features. Okay, we have right from the central nervous system to all the skin and skeletal muscular system. All systems can be involved. So it is very difficult to make a clinical diagnosis when a patient presents with the symptoms of systemic lupus erythematosus, so shortly called as SLE. Fine? Yes. So remember, for all those purposes, for easiness to diagnosis, the American College of Rheumatology has established a complex set of criteria. Even that criteria is also very a bit complex, because it takes into account almost all the features, and they have given some specific score. And suppose if we put score for each of the features, and finally if you came to know that the score is more than a particular number, we say that yes, this patient is having the SLE. Fine? Yes. So before going to that, we have a spectrum of autoantibodies, because SLE is an autoimmune disease. Whatever autoimmune disease, there will be some autoantibodies which will be directed against some antigens. Okay, autoantigens, so the self-antigens. So remember, the hallmark of the SLE is the production of the autoantibodies. Out of that, the most important or the diagnostic, we have I will show the table from Harrison. We have a lot of autoantibodies which are implicated in the pathogenesis of SLE. But out of that, we have some antibodies which are called as the most common antibodies, or we have some antibodies which are called as specific for SLE, okay, and so on. So we will discuss all that in detail, don't worry. Remember, out of that, as per Robbins, as per Harrison, the most specific antigen is what we call it as the SM antigen. What is the antigen? SM. Okay, that is nothing else but the Smith antigen. Okay, Smith antigen. Okay, these are nothing else but what is actually the Smith antigen? These are nothing else but antibodies against double-stranded DNA. This is the most specific. Okay, suppose if in a patient, if you are performing indirect immunofluorescence, we can detect all these. Okay, see all these anti-nuclear antibodies, they can be detected with the help of a technique called as indirect immunofluorescence. Okay, of course, remember and as far as SLE is concerned, the antibodies are mainly targeted against the various components of the nucleus. That is why we call it as ANA, that is anti-nuclear antibodies. Fine. We have 4 categories, that is against the antibodies may be produced against the DNA, they may be produced against the histones, against the non-histone proteins, or against the nucleolar antigens. Fine. Yes. So they can be detected by using indirect immunofluorescence. We have different types of each of these what antibodies know in immunofluorescence. It looks like some different patterns. We will come to that pattern. So please remember these 4 categories. One is what we call it as the DNA, histones, known histones. Known histones means whatever RNA and all, and finally nucleolar antigen. It's nucleolus. Okay, nucleolar antigen. Fine. So we have the spectrum. Out of that, remember the most specific antibody. Okay, this is straight away MCQ question. This is a straight away MCQ question. The straight away MCQ question. What is it? Okay, 1 second. Yes. This is a straight away MCQ question. That is nothing else but what is the most specific? This is I am writing here. That is the most specific. Okay, this is the most specific antibody which are directed against the systemic lupus erythematosus. Fine. Yes. So once this is done, I told you, yeah, see, this is a table straight away from the Robbins. Okay, you should be thorough. Okay, and as far as SLE is concerned, around 95 to 100 will be mostly testing positive for multiple nuclear antigens. That means what do you mean by multiple nuclear antigens? Here, the antibodies will be produced against say the DNA, RNA, everything. That is multiple. Okay, all those I told 4 patterns are there. Yes, all those 4 may comes here. That is 95 to 100. And out of that, the specific for SLE, see, specific for SLE is nothing else but the Smith antigen. Okay, Smith antigen. And next we have something what we call it as another double-stranded DNA. Okay, antibodies which are directed against the double-stranded DNA. So that is again also specific. But most specific, characteristically specific means we can go for double-stranded DNA, and before that we can go for Smith antigen. Okay, yes. Smith antigen is specific for SLE. Why I told specific for SLE? Because in no other conditions you will be having this antibodies will be expressed. Okay, mainly only in our systemic lupus erythematosus these antibodies will be expressed. That is why anti-Smith antigen. Fine. Yes. Then we have ROLA, that is SSA, SSB antibodies. Out of that, remember that is actually more diagnostic of Sjogren's syndrome. Sjogren's syndrome we will discuss later. But as far as SLE is concerned, it is most commonly associated with neonatal lupus. Then another one is what we call it as double-stranded DNA. Remember double-stranded DNA, see, around 40 to 60%. After the multiple nuclear antigen, the second is double-stranded DNA. That is why I told you that double-stranded DNA is double-stranded DNA and Smith antigen. Both these two are most specific for SLE. Out of that, double-stranded DNA is associated with the double-stranded DNA is associated with the what? SLE. It is also specific for SLE, but SLE with the nephritis. We will see. Okay, in SLE, one of the most important complication is the renal injury. That is a kidney failure. Okay, in that we have different classes of nephritis. Okay, we will discuss that. Out of that, if a patient is having SLE with the nephritis, double-stranded DNA is more specific. Or else, generally, if they are asking question, you can go for the answer. SM antigen. Okay, yes, SM antigen. Fine. SM antigen is specific for SLE. If it is SLE with nephritis, we can go for double-stranded DNA. So I hope you are clear with this. So these are the various antibodies. Okay, various antibody. Let us have a look at the table from Harrison. This is a table from the 21st edition of Harrison. Number 1, see, 98% prevalence is from the anti-nuclear antibody, multiple nuclear, and remember that is the best screening test. Okay, that is the best screening test. Then remember, next comes 70% anti-double-stranded DNA. Anti-double-stranded DNA, remember they are high titers for SLE specific, also most commonly associated with nephritis and SLE. Then anti-Smith, that is anti-SM. Okay, here the antigen recognized is nothing else but U1 RNA. This is also specific for SLE. Okay, yes. Then next is what we call it as antihistones. And remember, antihistones is more frequent in drug-induced lupus. Okay, we have discoid lupus, drug-induced lupus. Out of that, I am telling in drug-induced lupus, which antibodies are more specific means if they ask a question, that is antihistone. Okay, antihistone. And in my Instagram page, I will soon put a table. Okay, a table, because in Robbins they will be telling one thing, in Harrison they will be telling another thing. But as per some references from the MCQ books, or as suppose if they are asking a question in your postgraduate entrance exam or any MCQ exam, how you should approach. So I will straight away give one-liners. Okay, one-liners I will be giving, and I will be posting in my Instagram. You can watch from that. Fine. Okay, you can go through that. So antihistone, it is more frequent in drug-induced lupus. And rest of the antibodies are not that much important. Okay. Yes. Okay. So once that is done, so remember these are the antibodies. Then I told we can see what we call it as indirect immunofluorescence. See, in indirect immunofluorescence we can see some different patterns. Okay, the first pattern what I am showing, this is nothing else but what we call it as the homogeneous pattern. What is that called as homogeneous pattern? Remember, whenever there is a homogeneous or diffuse nuclear staining, it indicates that antibodies are directed against double-stranded DNA. Double-stranded DNA. I told you, double-stranded DNA means, what does it means? Yes, double-stranded DNA. Yes, double-stranded DNA, then chromatin and histones. Double-stranded DNA, chromatin and histones. So occasionally only double-stranded DNA. So whenever you get a homogeneous or a diffuse staining, your answer should be either antibodies are directed against chromatin, histones. Fine, chromatin and histones. The second is nothing else but what we call it as rim or peripheral staining. Rim or peripheral staining, it is almost similar to that of the homogeneous or diffuse nuclear staining. Here it is the antibodies are directed against double-stranded DNA. See, actually homogeneous or diffuse staining and rim or peripheral staining, both of this, in this you can say that the antibodies are directed against double-stranded DNA, chromatin, histones, all those things. Fine, yes. Then here comes, okay, yes, okay. Then you can see picture B here. This is nothing else but what we call it as speckled pattern. This is what we call it as speckled pattern. Speckling. Okay, this is called as speckled pattern. Remember, in speckled pattern, antibodies are directed against SM antigen. SM means what? Smith antigen. Okay, that is what, yes, fine. Then the pattern C. See, you can see within the nucleus, you can see some dot-like structure. This is what we call it as nucleolar pattern. What is this pattern called as? Nucleolar pattern. Remember, this nucleolar pattern is most commonly associated with the systemic sclerosis. Very less significant. Okay, I told you, speckled pattern, this is the most common pattern observed in SLE. Most common pattern in systemic lupus erythematosus is speckled pattern. Remember, speckled pattern means SM antigen. Okay. Then we have the nucleolar pattern. Nucleolar pattern means here against the nucleolar antigens, it is most seen in systemic sclerosis, okay, and other diseases. Fine. Yes. And finally, what you can see in this picture D. Okay, picture D. Sorry. Picture C, the picture C is nothing else but it is anti-centromere. Okay, this is anti-centromere antibodies. Okay, this only you can see in scleroderma or systemic sclerosis. Fine, sorry. Yes, and the final picture D, you can see just a single dot. This is nothing else but nucleolar. Antigens. Okay, this is nothing else but nucleolar antigen. See, centromeric pattern, nucleolar pattern, and the most common observed pattern is speckled pattern. In speckled pattern, yes, S for yes. Okay, that means the antibodies are directed against the SM antigen. Rim or peripheral staining, homogeneous or diffuse nuclear staining usually reflects antibodies to chromatin, histones, and occasionally double-stranded DNA. And rim or peripheral staining, if they ask you specifically, most often indicative of antibodies to double-stranded DNA and sometimes to nuclear envelope proteins. Fine, yes. So these are some of the most commonly involved antibodies. So far we have discussed about what is systemic lupus erythematosus. Then we have discussed what are the various types of autoantibodies, both from Harrison and Robbins. Then we have discussed the 4 to 5 patterns. Okay, 4 to 5, that is a speckled pattern. Then next we have the homogeneous diffuse nuclear staining, rim or peripheral staining, nucleolar pattern, and centromeric pattern. Fine, that is the indirect immunofluorescence is the name of the technique. Fine, yes. So far we have discussed the various spectrum of autoantibodies. Remember, as far as SLE is concerned, there are some other antibodies. I told in Harrison lot of antibodies that name has been mentioned, but in Robbins they have mentioned 2 additional antibodies. One is called antiphospholipid antibodies. Out of antiphospholipid antibodies, remember the antibodies which are directed against beta-2 glycoprotein complex, okay, is of important. Okay, it is of significance. Why? Because these antibodies will bind also to what? Cardiolipin antigen. Okay, so in systemic lupus erythematosus patient, what they will test have a false positive test for syphilis. You know, in cardiolipin antigen we will be using in what our VDRL, all those for syphilis. Am I right? Yes. So and at the same time, these antibodies will interfere with the in vitro clotting test, like what PTT, that is partial thromboplastin type. That is why these antibodies are called as lupus anticoagulant. Remember, lupus anticoagulant detection, antibodies to beta glycoprotein detection. It is one of the very important tests that we use in antiphospholipid antibody syndrome. I have already discussed what is antiphospholipid antibody syndrome in chapter hemodynamics, so you can go and refer there. Antiphospholipid antibody syndrome, okay, it is actually a hypercoagulable state. A female with the history of recurrent abortion, recurrent miscarriages, we have to always think about antiphospholipid antibody syndrome. Beta 2 glycoprotein antibodies are produced against beta 2 glycoproteins, and here since these antibodies will what interfere with the in vitro clotting test like partial thromboplastin type, these antigens are also called as, that is, it is called as lupus anticoagulant. It is anticoagulant. Fine. That means hypercoagulable state. Fine. Remember, hypercoagulable state, that is antiphospholipid antibody syndrome. Okay. Once this is done, the most important part. So far, all these what I have discussed, that is what is that? Antiphospholipid antibody syndrome, beta 2 glycoprotein, lupus anticoagulant, false, you know, these SLE patients will have false positive test for syphilis. Why? Because these antibodies will also bind with the cardiolipin antigen. Okay. Now I am going to discuss about the pathogenesis. Okay, now I am going to discuss about the pathogenesis of systemic lupus erythematosus. So this is one of the point where you have to focus. Why? Because this is the one thing you are going to elaborate in your prof exam. As far as pathogenesis of SLE is concerned, three important things. Okay, that is, there will be some genetic factors, number 2 some immunological factors, and number 3 some environmental factors. I told you, in autoimmune disease, these are the three main etiology for pathogenesis. So what is the fundamental defect actually? Loss of, what is the fundamental defect? It is nothing else but failure of the mechanism which maintains self-tolerance. That means no self-tolerance. Self-tolerance is absent. That is why body starts attacking its own antigen. Fine? Yes. Here, SLE is a genetically complex disease. Am I right? It is associated with the lot of MHC and non-MHC genes. Okay, yes. Out of that, I'm just going to highlight only the key points. You are also going to note down only those high points. Don't read in between the lines. It's not that much. It's not at all essential. Okay. For writing genetic factors, you are going to put the heading in below that. You are going to write number 1, HLA-DQ. HLA-DQ. It is what? HLA-DQ, that too which produce anti-double stranded DNA, anti-SM and anti-phospholipid antibodies. So this HLA-DQ allele, okay, MHC, is also associated with what? Increased risk of developing SLE. Then some inherited deficiency of early ALE complement components such as C2, C4 or C1Q. Okay, you know, C1 esterase inhibitor, what causes hereditary angioneurotic edema. Similarly, C2, C4 or C1Q, whenever these complement components are deficient, they may also predispose to what we call it as systemic lupus erythematosus. These are the two important points you have to remember as far as genetic factors is concerned. Then coming into the immunological factors. In immunological factors, first thing, failure of tolerance self in B cells, activation of CD4 helper T cells, then toll-like receptors engagement by nuclear DNA and RNA. Okay, finally immune complex deposition, these immune complexes will be deposited in the tissue, that will cause further tissue injury. And remember, there will be whenever there is TLR engagement by the nuclear DNA and RNA, okay, which are contained within the immune complexes, which will activate the B lymphocyte, which causes increased production of anti-nuclear autoantibodies. And finally, most importantly, type 1 interferons. What is that? Type 1 interferon. So just write the point. Okay, how many points I have told you? Number 1, 2, 3, 4. Okay, you are going to write these 4 points. Okay. Then finally, you are going to write the heading, that is environmental factors. What are the environmental factors? Exposure to ultraviolet rays. It will exacerbate the disease in many individuals. Fine? Yes. Why? Because the UV light will stimulate the keratinocyte to produce interleukin 1. This interleukin 1, no, it will promote inflammation. Then another thing, drugs. What are the drugs? Usually we call this as ship drugs. We have Okay, what we call as hydralazine, procainamide, D-penicillamine, all these, they will cause us SLE-like responses in humans. So these are the some groups of drugs which will cause us what SLE. These are also actually, they won't produce the classical features of SLE. Why? Because that is why we have a separate entity called as drug-induced SLE. Okay, drug-induced lupus. Yes, can anyone remember? Yes, I told you. Antihistone antibodies are most commonly implicated in drug-induced lupus. This has been a straightaway MCQ question. So antihistone antibodies have been straightaway what it has been implicated in what? Yes, drug-induced lupus. Fine. So what are the drugs? Hydralazine, D-penicillamine, as well as procainamide. Okay, procainamide. Fine. Yes. Hydralazine. S stands for. I will write it. S stands for sulfonamides. H stands for hydralazine, I stands for isoniazid, P stands for procainamide. These are the ship drugs. We usually say in pharmacology, ship drugs causes SLE-like features. Okay, yes. Now let us see a model for pathogenesis of systemic lupus erythematosus. Okay, yes. Then before that, let me see some of this is a picture from Harrison. See, what are the predisposing factors? Genes. In genes, see, C1q, C2, C4 inherited deficiency. Then what are the HLA? HLA DRB1. See, remember this is a very important MCQ question. In many PG entrance exam they have asked. This is not mentioned in Robbins. HLA DRB1, DR3. Okay, most commonly associated. Then another one is nothing else but, see again, HLA DR3 is most commonly associated with SLE along with the lupus nephritis. Whenever SLE with the lupus nephritis, what is the antibody which should come into your mind? Very good. Antibodies against double stranded DNA. Smith antigen, it is only SLE, pure SLE, no nephritis. If it is with nephritis, you have to go for the option double stranded DNA. Then environmental, ultraviolet light, smoking, Epstein-Barr virus infection, all those. Then some histone modifications, which is not that much important. So you can see here there will be some abnormal immune response. I told activation of B lymphocyte, inflammation, finally tissue damage. It may cause what? Tissue damage in almost all structures, right from head to toe. The patient will have clinical features. Now let us see the model. Okay, that is actually, this is the picture that you have to draw. Okay, in the your essay question or in your prof exam, when they ask you, this is actually the picture you have to draw. Whenever there is any susceptibility genes or external triggers like UV radiation, all this will stimulate what B and T cells which are specific for self-nuclear antigens will be activated, or whenever there is an increased burden of nuclear antigen, anti-nuclear, so antigen antibody complexes. Actually I told you, SLE is a type of type 3 hypersensitivity reaction. So immediately you have to remember what is the pathogenesis, what is actually happening in type 3 hypersensitivity. So what will happen? In antigen antibody complexes will be deposited. These antigen antibody complexes will be endocytosed. Am I right? Yes. And finally this will also further stimulate the B cells and dendritic C cells. Then interferon gamma will come into actions. All this will further produce high level of anti-nuclear IgG antibody production. In a single line I am telling, in systemic lupus erythematosus, fine, autoantibodies due to this susceptibility genes or due to environmental triggers. First, autoantibodies against nuclear antigens will be produced. Okay, that is not that much a problem. This antigen will interact with the antibodies to form what will happen? Antigen-antibody interaction, immune complexes. And remember, this immune complexes will further, it is going to aggravate, it is going to further activate the B cells and dendritic C cells. Hence, there will be hyperproduction, very high level of production of antibodies against this nuclear antigen. That is the major reason for this multi-system manifestations. It won't stay within a single system, because normally whenever there is an immune complex, what will happen? This immune complex will get deposited in the tissue, that will cause tissue injury, finished. But here, not only the pathogenesis is not finished just by simply depositing in the tissue, but what is happening? These immune complexes will further trigger the activations of T cell. The T cells, all those by interferon gamma will come into action, further activation of T cells and B lymphocyte. So there will be hyperproduction of IgG antibodies against nuclear. So that is, antibodies against the nuclear antigen will be continuously produced. Hence, it is what called as a multi-systemic disease. I hope you are clear with this. Okay. Then mechanism of tissue injury, I have already told you, it is like a type 3 hypersensitivity reactions. Okay, type 3 hypersensitivity reaction. And here, one very important thing you have to remember. Okay, there will be low levels of serum complement. Okay, this is a very important question. I think in JIPMA they have asked this MCQ question. Okay, what is the level of complements in type 3 or in systemic lupus erythematosus? It is decreased. Why it is decreased? Because these complement proteins, everything will be what consumed for the formation of these immune complexes, and which will cause us tissue injury. That is why in blood, in serum, the complement level will be decreased. Okay, and finally remember, okay, sometimes the nucleus, okay, when this causes tissue injury, the nucleus of the cell will be exposed. The nucleus of the cell will be exposed. So the anti-nuclear antibodies will bind with these immune complexes. Fine? Yes. So this nucleus of damaged cells react with the antibodies. They will lose their chromatin pattern. They become homogeneous to produce what we call it as LE body. That is lupus erythematosus bodies, also called as hematoxylin bodies. Okay? Yes. And suppose, yes, so these LE bodies are engulfed. Okay, suppose if it is engulfed by any leukocyte or macrophages, that macrophages or the so formed macrophages or neutrophil which is present in the blood, we call it as LE cell. So don't confuse LE bodies with the LE cell. What is LE bodies? When the cell get damaged, nuclei will be exposed. The damaged nuclei bind with immune complexes. Fine. There will be loss of chromatin. Homogeneous structure called as hematoxylin bodies or LE cell is formed. This LE cell will be engulfed by the neutrophils and macrophages present in the blood. And now, after engulfing this LE cell, the neutrophils and macrophages which are present in the blood is what we call it as what? LE cell. So that is LE body. This is LE cell. Okay. Remember, this is very, very important. Okay, yes, fine. Then antiphospholipid antibody syndrome, already the features of which we have discussed. Fine. And remember these antibodies crosses blood-brain barrier, so there will be neuropsychiatric manifestation like cognitive defect, dysfunction, and CNS abnormalities. So today, so in this session, so far we have discussed in detail about what is actually SLE. Fine. Then what are the spectrum of autoantibodies in systemic lupus erythematosus? In the next session, I will prepare a table. Okay, regarding only the autoantibodies, because I told you there is a controversies between the Robbins as well as Harrison. So I will refer some MCQ books and all, so that I will prepare one-liners. So you can just remember that. Okay, you can just by heart that, and you can solve straight away one-liner or direct MCQs. So they will ask what is the most specific, what is the most common, what is the most common in lupus nephritis, okay, most common in neonatal lupus. All those lot of entities are there. I will prepare a very beautiful table, and in the next session, that is the second part of the systemic lupus erythematosus. That is the first thing I am going to discuss. So as just of now, for your exam, for your university prof exam, you can't manage with that. For that, you have to refer only. You have to suppose examine in Viva or for your exam or whatever thing the examiner asks you, you have to refer only what is given in your Robbins. This is the small table. Okay, a cutout of a big table I have presented. So please refer only this. Okay, as far as this is concerned, multiple nuclear antigen followed by double stranded DNA followed by SM antigen. Specific for SLE, SM antigen. If SLE along with nephritis, double stranded DNA. Okay, these are the three important things. Then this is table from Harrison. Out of that, here antihistone, drug induced lupus. Please go through the 4 patterns. Speckle pattern is most common, and lupus anticoagulant. Then pathogenesis, genetic factors, immunological factors, environmental triggers. Okay, so this is again the pathogenesis. Remember HLA-DRB1, HLA-DR3, DR3 and DQA2. Then ultraviolet light, smoking, Epstein-Barr virus infection. Then see, this is the model. I told you, repeated activation. Okay, repeated activations of the T cells, interferon gamma, everything causes hyperproduction of the immunoglobulin against the anti-nuclear antigen. Remember what is LE cell? LE cell means what? The nucleus, when it fused with the immune complexes, becomes homogeneous. Chromatin will be lost. That is called as LE cell. That is called as LE bodies. When these LE bodies are engulfed by the neutrophils or macrophages which are present in the blood, the modified macrophage is what we call as the lupus erythematosus, also called as hematoxylin bodies. Then I have told you about antiphospholipid antibody syndrome. Remember 2 points. Antibodies are produced against beta-2 glycoprotein. So SLE patients will have false positive syphilis test. Why? Because these antibodies bind to cardiolipin antigen. Finally, remember there will be some neuropsychiatric manifestations because these antibodies will cross the blood-brain barrier, causes cognitive dysfunction and CNS abnormality. It is a type 3 hypersensitive reaction. Complement levels in the serum will be decreased because of the consumption of this complement for the formation of immune complexes. So in the next session, I will be discussing about the morphology, because in morphology it's a very huge thing. So if I discuss, so you will get saturated. So please, you can stop here. You can stop watching the video here. You can go back, take your Robbins. Please read SLE very thoroughly, because other than in pathology, in rheumatology, okay, at that time also they will be asking you to read only from Robbins, because this is more than enough as far as SLE is concerned for an undergraduate, I believe. So in the next session, we will be discussing the morphology, that is nephritis, lupus nephritis. It's just what separate short note question for you in your exam. So at that time, we will in the next session, we will discuss in detail about the lupus nephritis, see the various morphology, then the clinical features, EULAR classification, the scoring, and finally, some few words about the common treatment available as per the recent edition of Harrison. So I hope you are okay with this session. So please go through that. And the next session, in the first, what I am going to discuss is, I will give you a beautiful table about what are the most specific and most common antibodies you will encounter in various varieties of lupus, like drug-induced lupus, neonatal lupus, lupus with nephritis, all those stuff. Okay, thank you.